Our last talk for the session is Dr. Neeraj Israni, who's going to be speaking on my first secondary IOL.
Thank you, Dr. Zain. So my talk for the day is my planning your first secondary IOL. So in my case, the first secondary IOL that I planned was the iris claw. So most of my talk is on the iris claw. Now, complications are one thing that are imperative. It is something. It is said that if you don't have complications, you're either not operating enough or somebody else is operating for you. So I believe that it is a phase of your life, and it is a phase of every surgeon's life, and you have to just be with it. Now, what are the indications for a secondary IOL? So, when we see management of aphakia, it can be during a primary surgery or it can be during a secondary surgery. So, just noted down certain points like crystalline lens subluxation, IOL dislocation, capsular loss during cataract surgery, or any complicated phaco for senile cataract can be some of the causes for a secondary IOL. So what are the surgical options that are actually available for correcting aphakia? So I believe that transscleral sutured PC IOL is probably the best because it is the closest to the nodal point. However, we all know that it has a very steep learning curve, and you have to actually practice a lot of cases, only then you become an expert. Angle supported ACIOL is something we've all done during our residency days, and we've all started with those kind of ACIOLs. Then came the iris fixated or the iris claws, which have been there since quite some time. So if you see, the first ever iris fixated lens was the Binkhorst and the Worst iris clip. And this is actually a picture from 1980 from the Indian Journal of Ophthalmology. And if you see the encluvation at one of these points, so if you see the encluvation over here, I'm sorry, it's not. If you see the encluvation, it's slightly superior temporal, and it's not temporal. That was probably because in the initial days it was easier because the side ports were made on a different axis. And the artisan aphakic IOL, which is not very freely available in India, that was again one of the FDA approved ones in 1995, I believe. Now, like I told you, my talk, because this was my first secondary IOL, so we know that the iris claw can be clipped anteriorly or posteriorly, and the anterior reasons are different, and it's mostly for correction of myopia, and posteriorly, the iris claw is put mostly for aphakia. So this is one of the patients that I had seen, not operated by me, but as long as the iris claw is placed and incubated, it is very close to your endothelium. So the chances of a decompensation are very high. And this is another patient where post-trauma of the anterior placed iris claw, there was a trauma and it actually got de-incubated and started causing a little bit of decompensation. Whereas in case of a retropupillary iris claw lens, as you can see, the results are much more better. Now, what is the usual situation that we need this? So obviously presence of aphakia, that's the first thing. If there is a vitreous prolapsing, if there is a lack of capsular support. And so it's said that for iris claw, you need two things. One is iris and the other is iris claw. So it's very important that you should also have the iris. And just want to say that when you perform a vitrectomy, there are certain things that you should keep in mind. Your vitrectomy probe should be placing upwards, and it should be slightly more posterior as compared to the anterior plane, so that it actually sucks all the vitreous. And make sure that you don't sweep the iris, because like I said, iris is very important in this case. So the first thing that is there is to free the anterior chamber with the vitreous that I've already explained. And you have to make sure that the vitreous is cleaned completely. Yeah. So the second is basically to assess the iris. So if you see the pupillary zone, that is the area where there is constrictor pupillae. So that is the area where you're not supposed to enclavate. And the mid periphery of the session, mid periphery is the area where you actually enclavate it. So I'm just going to quickly show a video over here because we are short of time. So this was a case of a subluxated lens. And if you see over here, we planned a SICS for this patient. And what we saw that because it was a subluxated lens, we could actually not salvage the lens. And during the explantation of the lens, there was also a lack of iris. But I still went ahead and I performed, I took the iris claw and I had a good support because my side ports were temporally at 0 and 180. That's very important in iris claw, that your side ports are not aligned at 11 and 2 and they're actually temporal, so that you can actually enclavate the iris claw really well. So I'll just forward to the, so we had the vitrectomy done, and as you can see, that's my iris claw. Now it's very important that when you take the iris claw, you actually tent the iris claw in this position and then enclavate it. So that actually gives you a good, and you hold the optic in the center. So I'll go to the next video because we are short of time. Can we conclude? Okay, so I think we have short of time. Yeah, so these are few of the lenses that are available in the market. And yeah, these are few of the IOL holding forceps. I use the Leberman forceps from Appasamy, the T forceps. So lastly, just my last slide, I'll just take a minute. So it is important to learn from our complications, and complications are a part of a surgeon. So, iris claw is one of my first secondary IOLs. And yeah, that's my talk. Thank you.